I think we are good to go. The YouTube live streaming is on, right? So, good evening, doctors. We are happy to welcome you once again for today's Impact PG. And good evening, all the students. We are happy to welcome you once again for this Impact PG. As you are aware, for the first time, we are trying to connect with some international faculties today on today's case discussion on exacerbation COPD. We are happy and honored to welcome Dr. Cyril Jacob Jacko today for today's session, and Dr. Sunish Tilak for today's event. I'm sure both the students, Arya as well as Parvati, are going to have really a good session of exchanging their thoughts and their knowledge. And I'm sure equally all the audience will be equally getting benefited in this knowledge dissemination process. So with this short introduction, I would right now hand over this session to Dr. Cyril to just quickly give a brief and then hand it over to Dr. Sunish and take it forward from there. Over to you, Dr. Cyril.
Doctor, you can take the presentation.
Okay, thanks for inviting us for the session. Thanks to Dr. Muralidharan and thanks to ANS Pharma. So what we will be doing today is we'll be doing a case scenario, a live or a real-based case scenario session. We'll run through the patient being reported by the ambulance crew to the ED, and from there to the ED and from to the ICU, and then from there we'll go from there. Okay. The case. So going through the process, we'll run through different aspects of COPD and how the patient can be taken forward. Okay. And Cyril, do you want to add on something?
Yeah. I'm sorry, I had a bit of a technical glitch there. Getting onto the but yeah, so as Sunish has mentioned, what we had planned to do was take you through a scenario, and you can answer it to the best of your ability, but we'll try to give you feedback at the end of a set of questions. We wouldn't be waiting till the end of the scenario. So it's a scenario that will be flowing through. I'm sure you'll understand as we start off the scenario and go through it. And we'll be giving you continuous feedback at the end of what you've answered as a set of questions, 3 to 4 of them. Are you clear on that? Is that okay, Arya and Parvati?
Yes, sir.
Yeah. So
ready?
shall I start off, Sunish?
Yeah. Shall I share the screen, or you want to share it?
You go for it. I think
I will share the slide and then we'll run through. I will explain the scenario and then we can run through. Okay. Is my screen visible now?
Yes.
Okay. So the patient, the ambulance crew have alerted that Mr. H, a 72-year-old gentleman, he has presented with 3-day history of worsening breathlessness and productive green sputum. And he has called the ambulance crew that he's very unwell and he needs to come to the hospital. So they are pre-alerted the background and other details to the ED. So they have handed over what is happening and they're expecting a patient coming to the ED. Background of severe COPD, a previous smoker. He's on triple therapy inhaler. Functional status, he is living alone, climbs 1 flight of stairs, independent with his activities of daily living. And on examination, he is anxious and alert. His respiratory rate is 32, he is tachypnic, just widespread wheeze and reduced air entry at the right pace. So, Arya and Parvati, what do you infer from this information?
He's a 72-year-old male who is a known case of severe COPD, reformed smoker. He has at present presented with complaints of worsening of breathlessness with productive green sputum. So, based on the history, my probable diagnosis probably will be acute exacerbation of severe COPD, secondary to an infective pathology, probably a community-acquired pneumonia. And based on examination, he has got a respiratory rate of 32 per minute with bilateral V's in the chest. So can be classified as severe COPD at present.
Why would you
Okay.
say it's infective exacerbation, Arya?
Uh, because he complains of breathlessness with a green sputum.
Yeah, I mean, the green sputum can also, I mean, I'm just playing the devil's advocate here. You've got an exacerbation of COPD, but near an examination, particularly because this is a bit of an examination guided session, don't come to conclusions, because sometimes the examiner can pick you on that, just same as I've picked you here. You can say that this is an exacerbation of COPD. To say that this is an infective exacerbation of COPD, you need a bit more details here. So they're just trying to guide you in the right direction. You get my point, what I mean?
Yes, sir.
So carry on then, Arya. What do you understand by triple therapy? Arya or Parvati, who wants to take that on? And what implication does that have for the disease severity?
Triple therapy means inhaled corticosteroids. Patient is on inhaled corticosteroids, then beta agonist, then
Yeah.
muscarinic
Antagonist.
antagonist.
Yeah.
Have
And
you read through
what
the gold criteria? Yes, sorry, Cyril, please go on.
Yeah, I think that's exactly what I was going to ask.
Pardon, sir?
The gold criteria 2025 for COPD. Have you gone through that to see what therapies these people get? And these all have implications to us when they present to the ED, or when the ED calls us for whether this patient is potentially a candidate for ICU.
Based on the gold criteria, the COPD can be divided into mild, moderate, and severe. Based on the respiratory rate saturation.
What would you understand by triple therapy? You said that they are on 3 medications, but how would you then classify your disease process based on that, Parvati? Sorry, Arya. Would you say it would be mild, moderate, or severe, or where would you place this patient as in terms of severity of COPD?
Severe COPD, sir.
Yeah, I agree with you. Then that's based on the fact that they haven't responded to the dual bronchodilatory therapy, that they started them on the triple therapy. So based on the number of exacerbations they've had over the last year, they've been moved on to the next level of treatment. So that gives you an idea that this patient is probably quite a severe COPD in terms of chronic or obstructive airway disease candidate.
And adding on to that, so the triple therapy means a long-acting muscarinic, LAMA, that's what we call long-acting beta antagonist. So you use long-acting beta antagonist and long-acting muscarinic antagonist. And if the patient is having more exacerbation, as Dr. Cyril told, get than 2 moderate exacerbations of COPD per year, and the blood eosinophil count as well is counted to that if it's more than 300, and history of concomitant asthma, they may be added on inhaled corticosteroid therapy. There are few contraindications or few scenarios where we don't use these steroids. Can anyone of you tell?
based on a blood count.
So if the eosinophil counts are less than 100, okay, and a patient gets repeated pneumonia when you put them on inhaled corticosteroids, and if they have a history of microbacterial infection, they will not be put on inhaled corticosteroid therapy. Okay, so just this all basic things just will find out in GOLD 2025 or any GOLD criteria. Just go through that before going for your examination. Okay, then.
So the next question is, Mr. H had an FEV1 of 28%. What does that? How does that classify in terms of severity of COPD?
COPD is defined by GOLD criteria, FEV1 by FVC ratio 0.7, and we can categorize them into mild, moderate, severe based on the FEV1 value. If the FEV1 value is more than or equal to 80%, it is mild. 50 to 79%, it is moderate. 49 to 30, it is severe, and less than 30, it is very severe. So this category, FEV1 of 28% is predicted, means it is very severe category of COPD.
Very good. Yeah, that's exactly what you would want to hear from in this. While answering that, you not only showed that you know the classification, but you've managed to classify this guy into the severe criteria of COPD.
Sorry, sir, I lost the initial part. My network connection was poor, so I didn't hear the questions previously asked.
Don't worry. Next question, Suresh, do you want to take it? We'll alternate, or do you want me to?
Okay. So the clinical implication of FEV1 28%, as you know, is very severe. So this means the patient has little physiological reserve. Okay. So you got two things. Patient is on triple therapy, FEV1 of 28%. So the patient, the physiological reserve is poor. That you need to keep it in back of your mind. Okay. But it is not all that matters when you take a patient to the ICU, but we'll come on to that as we go on. The next question is, what is BORD index? The GOLD criteria says just don't use BORD index for prognostication purpose, but we'll just touch on basis what is BORD index.
Okay. BORD index, the components include BMI, obstruction, dyspnea, and exercise capacity. Based on those patients having high BORD index, they may need a lung transplantation, or they belong to severe category of COPD.
Okay.
Lung transplantation?
No, sorry, sir. They belong to severe case.
Severe case, yeah. I mean, COPD is getting transplant is an extremely rare scenario. Globally also, it's a very rare scenario. More and more, you're getting the restrictive lung diseases that are getting transplanted, but COPD still are a group of patients that our transplant surgeons don't like to do, mainly because it's also has to meet the criteria of non-smoking, off alcohol, off nicotine for a significant period of time with a normal heart is quite and severe enough to trigger a transplant is extremely rare in this group of patients, unfortunately. By the time they're severe enough to have a COPD, by the time they're severe enough to trigger a transplant, their right heart is gone, and then they will fail the transplant criteria. So it's a bit of a vicious cycle in which they fall into. But they're very the percentage of COPDs that end up being transplanted are very low. Because of the reasons that I mentioned. So the next question, I think, is how would you classify the importance of his functional status and his clinical frailty score? Do you think that's an important bit, or how would you, in terms of your history, how high would you classify that?
His functional status means he leaves alone, climb one flight stairs. That means having an MMRC of grade 2 dyspnea as a baseline.
So what implication that does that have for you as an intensivist?
So he's more prone for more exacerbations.
But in terms of would you, the question here is, does he have the functional reserve to go through intensive care admission or does he not have it? Would you take him to intensive care based on that history?
No, sir.
No, you
Based
wouldn't.
on his functional status alone, we can't take him.
No, I mean, as part of that, you've got this as a history and this gentleman is in A&E and you have to make a decision whether to admit this patient or not to admit this patient. How would you base, what decision would you make and what is the basis of your decision on that?
We will consider
You
prior
have to justify your
exacerbations.
decision. Yes.
We have to consider prior exacerbations, any background comorbidities like
No,
congestive heart failure.
nope. He's had an echo 2 months ago. His right heart is fantastic. No issues on that front. Would you admit him?
Yes, sir. If he's symptomatic, I will.
Yeah, I mean, there's no right or wrong answer here. It's how you justify your answer. You think this patient would be able to benefit from a period of critical care support to get over this exacerbation and get back to his baseline. There would be, you would be justified in admitting this patient. If you think this patient's background frailty is so poor that he cannot withstand an insult of an acute exacerbation of COPD, then you don't admit him. It's just not based on one thing, it's based on multiple things. So you can, what I was trying to get to you is that you can't base your decision purely on your FEV1 or one aspect. You have to take the entire picture into consideration, which would include your clinical frailty score, your patient's metabolic reserve, and his physical physical ability. If he's active in ADLs, he can manage a flight of stairs, and manages to get do all activities of living. It would be one of those patients that you would consider for critical care treatment.
And if not, what will you do for this patient, Maria Pavali? If the critical, if you take into account, he needs support, and the frailty score is more than 7. So you classify the frailty score from 1 to 9. Okay, so if the frailty score is 1, 7, and 8, that means he's bedbound. He needs support for his activities of daily living. So what would you consider for this patient if the ED calls you to see this patient and advise on further management?
We can give I will give supportive care for this patient. If
What supportive care?
he is in respiratory distress, we can support with non-invasive mode of ventilation. We can give nebulization and other support. And we can discuss with the family regarding his prognosis, and we can wait for in we should ensure them that there is no point of going for any advanced resuscitative measures like invasive ventilation. But I can provide him other supportive cares like nebulization, IV antibiotics. If he's in infective exacerbation state, I can provide antibiotics and other non-invasive ventilatory support.
Very good.
So what if you've got a diagnosis here, I'll give you a bit more information. This patient has a temperature of 38.2, and you've got a white cell bag that is at 17. CRP is about 200, and PCT is 2. You've got a chest X-ray Sunish will show you in the next couple of slides. How would you diagnose this patient now?
By the clinical history, examination, and investigation, it is an acute infective exacerbation of chronic obstructive pulmonary disease.
How would you treat him?
First of all, I have to, as a part of emergency management, I have to stabilize airway breathing circulation. I have to check his vitals.
So you've given him 15 liters via non-rebreathable mask. You started him on a pulse oximeter. You put him on a pulse oximetry, ECG monitoring, put in a Venflon, and started off fluid. What else would you give this patient?
If patient is tachypneic, in spite of tachypneic, I will provide a non-invasive ventilatory support, and I also give
Before that, would you consider any other treatment?
nebulization can be given, sir, if patient is
What would
having
you
severe
nebulize?
bronchospasm.
What would
Usually
you?
short-acting bronchial dilators, beta-2 agonists, along with short-acting antimuscarinic agent, salbutamol of 2.5 milligram, and antimuscarinic agent ipratropium of 0.5
Yeah.
milligram can be provided. It can be repeated every 3 times every 20 minutes.
Yeah.
And also, if as this patient's counts are elevated and CRP, PCT, everything is elevated, I will start on IV antibiotics also.
Okay. So as part of your treatment, how would you monitor your treatment? What sort of investigation can you do to help guide your treatment?
I can do an ABG, arterial blood gas analysis, to
Perfect.
check whether patient is in.
If you want to have a look at the next slide, which will show you the blood gas that you have just taken from this patient. What do you
This
think of that?
patient was put on 15-liter oxygen via non-rebreather mask by the ambulance crew, and he is now in ED. So he has come to the ED. His GCS has dropped to 13. This is what the ED people took the gas, the blood gas, and this is what it showed.
This ABG is showing severe metabolic acidosis. Sorry, severe respiratory acidosis with metabolic compensation. Ideally, this patient, as the pH is 7.18, may need a invasive mechanical ventilation.
Let's go through that blood gas a bit more, actually, Parvati. Before we start out, what else can you tell me about looking at that blood gas?
Here, patient is having respiratory acidosis with a pH of 7.18, PCO2 of 86, compensation.
What about the oxygen?
What about
With the 15-liter O2, his PO2 is 135. We don't need this much PO2 in a patient with COPD because
But what do you think
it
of the
can.
PO2?
PO2 is high, sir, 135 with 15
For
liters.
15 liters, what would you expect your PO2 to be? It would be around 699, about 700. If you put in the alveolar arterial blood equation, which is PO2 into P atmosphere minus PO2 divided by R, it should come around to 600. 630 probably with this guy's PCO2, around 640 with this guy's PCO2, that will be slightly higher. So if I give you that information now, what do you think of this patient's PO2?
PO2 is inadequate.
It's probably what you're trying to hear is that you've got a big alveolar, a big AA gradient here,
Yes.
which would be, I mean, the multiple reasons for that. But what do you think would be the cause of that here?
Because of hyperventilation.
What hyperventilation would probably can give you. I'm not saying no. What else would you be? What would you think based on this patient's history? Hyperventilation mainly, what you would start thinking of mainly is hypercapnia, isn't it? You can get hypoxia. Don't get me wrong, but your primary ABG.
Consolidation will be done.
You're
Underlying
thinking about
consolidation will be there.
Yeah, you're thinking of a shunt or inadequate perfusion or a VQ mismatch there. Excellent. So he probably, based on, even though you've got a PO2 that looks very appealing, you're looking at a patient that's on 15 liters non-rebreathable, so it should be significantly high. Taking into consideration his previous history of COPD, you still would consider that he's got a significant VQ mismatch. You would expect this to be, say, a worsening of his blood gases. But to be 100%, you need to have a baseline blood gas when his fitness stage is fit and healthy before you can make that conclusion safely. But here, I think you could say that this looks like a significantly high AA gradient. What do you think? So you've got a high AA gradient or alveolar arterial mismatch. What else can you tell us about the blood gas? Anybody, Arya or Parvati, you know? Somebody had slightly hinted on it. I think you talked about compensation. What do you think about the compensation taking place here?
Compensation here, the PCO2 is 86. So every 10 millimeter rise in PCO2, the bicarb should rise by 1 millimeter in an acute setting.
In an acute situation, very good. In a chronic, how much should it rise by? 0.3 to 3.5. You look at the literature, it varies between 3.5 to 4. But yeah, 4. So what do you think of that? Based on that, how would you calculate it? So you've got a PCO2 of 86 here. So accept a PCO2 of 40 as being normal. So your rise is around
46.
46. So if it's acute, you should have a raise of bicarbonate by 4.6.
Around
4.6, which should get you around 24 is sort of your normal bicarbonate. So it will be 28. But if it's chronic, so this is not purely acute, is what I'm trying to get to you. You have an element of.
There will be increase in 16. If it is chronic, approximately about 16.
16. So which would take you to how much should your bicarbonate be?
If considering 16, it will be
40
around 40, around 40.
So what is your conclusion based on what you have just told me now? What would you say is happening to this patient? You're thinking in the right direction.
Actually, he's trying to compensate. There is
He's incompletely compensated, but you definitely would think that he's not a pure acute either. So he's how would you place him? How would you classify him in the spectrum?
We can consider acute on chronic respiratory.
Yeah, exactly. You've got an acute on chronic respiratory compensation here. That would be what you could conclude based on that gas, thinking about it in terms of going through it. What else? That would be the main things that I would go through when I get this sort of a blood gas sitting on me. How much would you expect? You said your bicarbonate. The other rule of your pH is that you should get a drop of pH of 0.08 for every 10 millimeters of mercury of rise in carbon dioxide. Again, if you look at that pH, it doesn't reach an acute or chronic. It's in between that. So that will validate your first conclusion that this is an acute or chronic COPD exacerbation. Did you understand that? Your pH should also drop by 0.08 for every 10 millimeters in an acute situation, while in a chronic situation, it dropped by 0.03. So this is again between that. So that is again another validation that you have an acute on chronic COPD exacerbation. Okay?
Yes, sir.
Next. So we went through.
Yeah.
Sunish.
So what is the reason for this high CO2? The CO2 has gone up, isn't it? From don't know what the CO2 was before, but the CO2 has gone up to this level. What would be the reason for this high CO2?
Because of the expiratory flow limitation, there is incomplete expiration. So
what is the basic physiology? You can go to the physiology and think about what has happened.
You've gone quite silent, Arya. Do you want to join in?
Yes, sir.
So
Go for it.
you have told about VQ mismatch before. You can think in that respect and tell me. So you've given lots of oxygen.
So the age-old myth used to be don't give too much oxygen to COPD patients because they thrive on the hypoxic drive, and if you give too much of oxygen, they end up having a CO2 retention. That's been proven to be wrong beyond doubt. But what exactly is you still get a CO2 retention in COPDs? Why do we get that?
Because of the ventilation perfusion mismatch,
What would you
there
get a
is
ventilation?
there is
What exactly might be the reason?
there is a rightward shift
You're
of the
right.
CO2 dissociation curve, whether
Just think, ventilation, you told right, ventilation perfusion mismatch is a major reason for CO2 rise. But what exactly is happening? Why there is a ventilation perfusion mismatch?
as the airways are get destroyed, there is no proper ventilation is occurring, and also there is expiratory flow limitation is there, which lead to
Yeah, there is
progressive
a poor
retention of
ventilation.
these
What you
two.
told is right, poor ventilation. Because of poor ventilation, what exactly is happening there?
I think somebody in the chat has mentioned the answer, actually. I don't think you guys get access to it while you're answering it, but it's come up in the chat.
Okay.
In COPD, hypoxic pulmonary vasoconstriction is the drive for ventilation.
Yeah. So what happens when you
gets,
give a high oxygen?
It get lost.
Why does
in
it get
COPD.
lost?
Because we are providing oxygen, and also there is
No.
a Haldane effect.
Yeah, you
Haldane
lose what? Yeah. There's two. You rightly. You lose what? You lose the hypoxic pulmonary vasoconstriction. Why? Because it's been proven. The hypoxic pulmonary vasoconstriction is dependent, interestingly, on the alveolar oxygen concentration, not on the arterial oxygen concentration. So when you're giving a high 15 liters, you're probably having 100% oxygen in your alveolus, which will obtend your hypoxic pulmonary vasoconstriction. And that leads to increased blood flow to the emphysematous or the bronchiectatic part of your lung, and that leads to increased shunt. Increase because you probably get a bit of oxygen unloading, but you don't get enough CO2 that is crossing across to the patient, and that leads to a rise of CO2. Again, the Haldane effect is, what was the Haldane effect? You mentioned it.
Haldane effect means a rightward shift of the dissociation curve, carbon dioxide dissociation curve, because of the decreased affinity of carbon dioxide to the oxyhemoglobin, which lead to increase in the carbon dioxide concentration in the arterial blood.
Yeah. It's a physiological effect in which you need to be helping to unload your CO2, and it's a opposite of Bohr effect in your patients. Yes, that's right.
And just a quick question: what is Bohr effect? It's a mirror image of Haldane. It's happening at the tissue level. Okay. So coming to the next question. What is the reason for... Sorry, what did you say?
Hello, sir. Can you hear me?
Yeah, yes, now I can. So what is the reason for his drowsiness?
Pardon, sir. Here the question connections. Because of the hypercarbia.
The basic physiology. What happens to carbon dioxide? Where does it go? And what's the reason for the drowsiness? So the carbon dioxide crosses the blood-brain barrier very easily, isn't it? So once it's crosses the barrier, the pH in the CSF is lowered. So it causes intracellular acidosis. This depresses neuronal activity. That's the reason for the drowsiness. Okay. And coming to the chest X-ray, tell me the signs of COPD. Just look at the X-ray and tell.
Can you hear me now?
Yes, yes. Come on, look at the chest X-ray. Tell me the signs of COPD.
A hyperinflated chest, barrel-shaped chest.
Yes.
And a flattening of diaphragm, both
Yes.
sides. Then
Inflation of the chest with tubular heart and flattening of the diaphragm.
Yeah. So you see all the classic features in this chest X-ray. Okay. And you look for anything else?
Increased opacities near the right lower lobe. Infiltrating the right.
There's some, you can't see the right costophrenic angle as well.
Yeah,
So there's
both are
maybe a bit of
blinded.
effusion as well. How do you confirm the opacity is in the right lower lobe on a supine film? Whether it's a right lower lobe pneumonia or whether it's a middle lobe pneumonia, how do you confirm that on a supine film?
There'll be sure, sir.
It's not clearly evident in this X-ray anyway.
It's not here in this X-ray. You get a, yeah. Sorry.
So is there a connection problem? I can't hear any of you talking.
Hello, sir. Can you hear me now?
And now, yes.
We can hear you, ma'am. Parvati, please continue.
Yes. So you asked about the opacity in the right lower lobe. That question,
it's
sir?
not evident in the chest X-ray, but you can tell how do you confirm that whether it's a right lobe pneumonia or a middle lobe pneumonia on a supine film?
In middle lobe pneumonia, the cardiac border will not be make out properly in a chest X-ray. If it is a middle lobe consolidation is there.
Yeah. And right lower lobe pneumonia?
There'll be diaphragm will be flattened.
So what is called by Silhouette sign?
Still outside. Absent cardiac border because of the lower lobe consolidation, middle lobe and lower lobe consolidation.
So the right heart border will be preserved in. Okay.
Yes, sir.
Sorry. Shall we move on to the next question?
Yeah.
Yes,
So if you're intending to start this patient on NIV, what safety checks would you perform before applying the mask?
First of all, we should look for any contraindication for starting NIV. That
Which
is
are?
related to patient safety measures. If there is any facial trauma or contusion, or is there, and also if the patient's airway is patent or not, we have to check first of all that, because if there is any severe vomiting or any upper GI bleed or any recent intra-abdominal surgery done or not, and also we have to look up the GCS also, whether the patient is having any CVA with bulbar palsy or patient is in comatose or stuporous state.
Yeah. So, I mean, you've very nicely sort of categorized it. The CNS signs where if this patient's GCS is too low, they won't be able to tolerate it. And there is gastrointestinal, where there's intestinal obstruction or things like that, where gastrointestinal obstruction more and more is becoming a relative contraindication, where we are becoming a bit more braver in giving them a non-invasive ventilation, even if they have an element of ileus and things like that. But I wouldn't quote that. I wouldn't say that in an exam, but for your practical, you can put in G tube and still start them on a bit of NIV. So in terms of his breathing, the other things that you probably would have to be, for the exam point of view, is look at if this patient has got a pneumothorax, rule out a pneumothorax, which would be worsening during this. Circulatory failure becomes again more or less now also a relative contraindication. Here we have a sort of a two-tier NIV service. It's not a two-system NIV service, where if the pH is less than 7.25, they come to ICU. And if it is more than 7.25, they're managed on the ward on an IV by the respiratory physician. So it's a slightly, that 7.25 number has come from practice more than anything else. So that is where they would go for us here, working here, if you find a patient in that situation. What information would you provide the family before you start off taking this patient to ICU and start giving NIV? How would you counsel the family about this?
I will counsel the family regarding his present condition. Now he is in severe COPD exacerbation and he is in severe respiratory distress. So we started him on a non-invasive mode of ventilation. Here we are supporting the patient. We have to monitor him closely. For that, we are shifting him to ICU. We have to assess him hourly. After 1 hour, we have to assess whether his dyspnea settled or respiratory rate gets settled, his vitals are got stable, and also we have to check an ABG whether the pH value is improving or not. If it is not improving, we want to put him on a invasive mode of ventilation. Simultaneously, we have to look after his hemodynamic parameters also.
Yeah. What else would you tell the family? Would you explain what if you failed this therapy?
If this therapy is failed, next option is the invasive mechanical ventilation. By putting that, we should also monitor him further whether there is any improvement or not. And also now the reason for exacerbation is an infection, so we have to treat that. I will treat that infection also. So I have to start him on antibiotics and check whether how is he responding to these therapies, and according to that we can escalate the treatment.
Yeah. No, I think that's a fair
How
enough.
far you will explain?
Yeah, carry on. How far would you?
So when you talk to the family, you need to talk what you will be expecting to do, what all complications you would be expecting in this patient, and how will be you mitigating that, and how far you will go with this patient when he comes to the ICU. All these things you need to explain to the family. Everything need to be clear and should be open. So regarding escalation, so this patient coming to ICU on an NIV, this patient will probably may or may not fail NIV. Then you are escalating to an invasive therapy, and once he's on an invasive therapy, what you are going to expect, how the pathway, how the patient travels on the invasive, and how we are going to get him out of the invasive ventilation. And if he arrests in between, whether he will be suitable for CPR, all these things need to be explained before. So coming to the question, you see, for full escalation from whatever we have grabbed from the history and what his physiological status is now.
From the history, he's in a severe very severe COPD stage. So if we are putting him on invasive ventilation, we can't predict how long he will be on invasive ventilation. We have to monitor him. We have to assess him hourly, and according to that, we have to change the ventilator settings. And during this ICU stay, he's also prone for any sudden cardiac arrest. Because this condition, this COPD condition can concomitantly aggravate this in underlying heart disease is there or not. Because of this condition itself, because of atopy development, this patient can go for any pulseless electrical activity or cardiac arrest. So there is high risk for this patient in putting in ICU. And if he's responding and his ABG values are improving, his respiratory distress is, got improved, and his consciousness got improved, we can we can de-escalate his ventilator settings and put him later. We can put him on any pressure supportive mode of ventilation, and we can give it a try for that. If it is not possible. Sometimes he may be he may require prolonged mechanical ventilation. In that situation, we will consider tracheostomy for that patient, and also his according to his background history, his functional status is also poor with a poor FEV1 ratio.
His functional status is not related to FEV1. Okay.
Sorry, sir.
His functional status is okay. He's independent or aerial. He can climb one flight of stairs. He manages his own daily living. So functional status reasonably okay, I would say. So that's the reason why you are taking him to the ICU for invasive ventilation. Okay. So I'm asking specifically about the escalation plan. If we arrest, there's one thing which you have to keep in mind. Some of the patients might have a respect form. They may have a wish that if they arrest, they don't want to be resuscitated. That's one thing which you have to clarify with the family, or whether the patient has some. So patient, if the patient is conscious, you can check with the patient as well whether he has any wishes, whether he wants to be put on an invasive ventilation, whether if he arrests, whether he wants to be resuscitated. All these things need to be clearly communicated with him if he has the capacity, or if he doesn't have to be communicated with the next of kin. That is what we do on a family communication. Clearly explain what we are going to do, and if in case he ends up in any complications, what we will do. So the journey we will explain, and then we will take it day by day. Okay.
Another thing, Parvati, you mentioned when you were answering that you would reassess this patient in 1 hour. That's a very, you said once you initially reassess in an hour. I wouldn't put a time frame to that. I would just say regular intervals I would assess this, because different units have different criteria. I've worked in units where they have to have assessment within 15 minutes regularly, because 15 minutes is what they say an intervention. The gases become changes in blood gas can be assessed. PCO2 particularly, rather than PO2. PO2 is all. So don't commit yourself, because it's not 1 hour. It might be. There's nothing wrong with that. It's just different organizations have different protocols. Just say it's a short regular intervals. I will be reassessing this patient to assess the effect of therapy and see how the patient is progressing. Okay. If they want a specific number, let them ask you. Don't commit yourself. They're asking, so how soon will you see it? Then you can say an hour or whatever is your unit. In our unit, this is it.
Yes.
Yeah. Right. So this has been the treat. Yeah, carry on.
Yeah. So now the next question comes in. We have talked about steroids. We have talked about antibiotics. We have talked about inhalation agents and other therapies for COPD. So first of all, we'll touch base with steroids. What is the steroid, or what steroid plan you will be giving for this patient as per the evidence?
In case of exacerbation, we can start him on systemic steroids. The recommended, if patient is tolerating oral, methylprednisolone 40 milligram once daily is the recommended. If patient is in severe distress, we can start on IV steroid also. Injection hydrocortisone maximum 200 milligram per day can be given.
Are you sure?
And how long?
Maximum 5 to 7 days.
I mean, you can go up to 100 QDS. I mean, again, the dosages will vary between, it's just like the timing that we mentioned earlier. I wouldn't commit, I just say that I'd give a high dose steroid. And if they want, let them ask it. I mean, some people do the sepsis dose of 50 milligram QDS. Some people go for 100 milligram QDS. It depends. Again, the respiratory physicians have a variable opinion on that. Bear in mind that some of these patients are chronically on steroids, so you might need to give a higher dose to get a response to them.
Okay.
And the duration, is there any trial which says that you need to, which has verified a longer duration versus shorter duration?
No, sir, dose more than 250 mg is not effective according to
Duration?
duration. 5 to 7 days, we can continuously give without tapering.
Yeah, we don't need to taper.
So
That's
yeah. What does have you heard about a reduce trial?
Reduced trial, yes, sir. Reduced.
5
According to
days
this trial,
versus 14 days.
14 days, no mortality benefit was with 14-day group, and also there was adverse events were more with 14-day group, like risk of hyperglycemia was higher in that group.
yeah.
And mechanism, how does the steroid act?
Steroid will reduce the inflammation, it improve the lung function, improve the FEV1 value, and thereby reducing the length of hospital stay and
How
ICU.
does it improve the FEV1 value?
It will reduce the airway inflammation, to reduce the mucus hyperplasia. It has an anti-inflammatory action.
It has an
That is
anti-inflammatory action, but would it definitely, I mean, will it reduce FEV1? We don't know. I mean, that's not an endpoint that you normally would measure with hydrocortisone. But yeah, it has a genomic and a metabolic effect where it will reduce the inflammation that is in the airway.
Thereby improving the lung
that is a bit more prolonged action. So it takes a bit of a while for the inflammatory action to kick in. So what is the fastest action which the steroid will give when you give steroid? Does it upregulate beta receptors? So it upregulates the beta receptors. Okay, that's the fastest action. Side effect here told hyperglycemia and possibly maybe ICU acute weakness, which we don't know. And coming to antibiotics, what antibiotics you will give?
Since this patient coming from a community, we can start him on beta-lactam and then
what is the criteria for using antibiotics? First of all, criteria why you want to put this patient on?
There is increased purulence of the sputum, increased volume of the sputum, and worsening dyspnea. We can if all three are there, that Ash.
Yeah.
Sir, Ash. No, I'm not remembering that name.
Anthony's criteria.
Anthony's criteria, sir. Sorry, Anthony's criteria. If all these three or increased purulence with any of the one is there, we can start him on IV antibiotics.
Okay, what antibiotics?
We can start with him on beta-lactam agent and a macrolide for atypical coverage. Beta-lactam along with atypical antibiotic, either macrolides, azithromycin or clarithromycin. In patient having any structural lung disease, we can give him on an anti-pseudomonal coverage.
Okay.
Okay.
Coming to other drugs, salbutamol.
Salbutamol, yeah.
A
How does
nebulized
it
form
work?
of sir.
Yeah.
How does it work?
It's a beta 2 agonist. It can cause bronchial dilatation.
What? How does it act on the beta 2 agonist receptors? Does it? What is the? It's a second messenger system that acts on CMP inhibition, adenylate cyclase, and increases the bronchodilation effect. How does ipratropium work?
It is a muscarinic agent. It will cause the relaxation of the smooth muscles around the bronchus.
How does it act? What is the mechanism of its action? Which receptors is it mainly? I mean, I don't know how deeply they'll go through in your exams. Here, we wouldn't be going that deeply into receptor level mechanism of action, but if they do, it's M3 muscarinic receptor action that it acts on. What are the contraindications for ipratropium?
Glaucoma.
Glaucoma, right? And what else could it cause as a side effect, particularly males? So
you may see a patient on an NIV on all these nebulizers very much combat and you think that it's delirium. What actually should be happening there? They put him on a nebulized ipratropium, and he's very restless and combative.
No, sir. No, sir.
Elderly gentleman, large prostate.
large prostate, urinary retention is quite common in that group. With that. Aminophylline,
Okay.
how does it work?
Sir, aminophylline is a methyl xanthine. It is also have a bronchodilatory property.
Yeah. How?
Nowadays, according to recent criteria, the usage of aminophylline is very much reduced. But in severe exacerbation cases, we can give it work by bronchodilation only.
Mainly again, phosphodiesterase inhibitor decreases CMP breakdown and increases CMP level within the body. It it is just another mode of action there, and can be additive to your use. Like you said, its use is coming down, but it's still being used a lot in COPDs for bronchodilatory effect. Yeah. What are the side effects?
Tachycardia, arrhythmias can occur with the use of aminophylline.
Tachycardia, arrhythmias. What else? It's got a very
therapeutic window.
Yeah. And so you have to be
What you
very,
need to
you
do,
have to keep titrating it.
if you have the facility, you have to send for aminophylline
Levels.
And what
Right.
else you use for in COPD patient? What are the medications you can use?
Mucolytics can be given.
What else?
Inhaled corticosteroids. If we are using IV steroid, no indication. Otherwise, inhaled corticosteroids in category E group, we can give.
That all things which we have discussed already. But anything else? Any other medications which we use? Probably the emergency department might have already given those medications before calling you. We use magnesium.
Magnesium, sir. Magnesium 2 gram can be given for a period of within 20 minutes in refractory cases of COPD.
What are side effects?
Hypermagnesemia can cause decreased urine output, absent reflexes.
So that's extreme
And
cases.
respiratory depression can occur with
Muscle weakness, it can cause potentiate the effect of muscle relaxants if you give muscle relaxants. Okay, and what's common side effect? Hypertension. If you give magnesium, you can get hypertension. Okay, it relaxes, isn't it? Blood vessels. And fluids. Do you give fluids for these patients?
Even if they are, some patient will be in core pulmonary stage, there may be edematous, but they may be because they may be in a fluid depleted state. So we have to assess the dynamic indices of fluid responsiveness, and accordingly we can give
Before
the
putting a
fluids.
patient on NIV, do you check for the blood pressure? The blood pressure is low. What could have been the reason for the blood pressure? Low blood pressure. It's been tachycardic for a while, and 3 days of breathing difficulty.
Maybe because of the development
he
of
has lost lots of fluids from his body. Okay, you need to give fluid judiciously, or fluid assessment. You can use different modality to assess fluid. Clinical, you can use ultrasound.
we can use ultrasound. Clinically,
so you can use multimodal assessment and give fluid. There is no clear-cut answer that you need to give this much amount of fluid. Okay. So what will be your NAV strategy? How will you start him on NAV?
If we are starting him on BiPAP, we have to set him IPAP and EPAP. The IPAP will be around, we have to set around 8 to 10, and EPAP will be around 4 to 6. And we can initiate the NIV, BiPAP, providing the pressure support by calculating, and we can further escalate the IPAP by looking at the patient's clinical condition. If we are starting on a ventilator NIV, we can set up the FiO2, PEEP, respiratory rate, and pressure support in order to provide a tidal volume of 6 to 8 ml per kg with a PEEP of minimal 4 to 5, and FiO2 to maintain the saturation of 88 to 92%.
So you have set up the patient on NIV and you are not getting the tidal volume.
First of all, we have to check whether there is any patient ventilator asynchrony may be there. We have to check for any bronchospasm is there or not. We have to give nebulization, and we have to set the tidal volume.
Do you tell the patient? Do you explain what you are going to do to the patient?
Yes. I will, first of all, I have to select a mask appropriate for the patient by measuring from the bridge of the nose to the chin, and appropriate mask has to be selected, appropriate interface has to be selected, orofacial interface can be selected, and we'll explain the patient. This is a high flow mask ventilation we are providing. You have to breathe along with that. This is in order to reduce your respiratory distress, we are starting this therapy. So you have to breathe along with that. Then we'll start on ventilation.
So what is the implication of less than 30 FEV1? So this patient might be having lots of air trapped inside. So,
Yes,
so they have to breathe in on top of that. So they have to use a lot of work, isn't it?
yes.
So what strategy you will use when you put the EPAP?
Sir, EPAP should be 2/3 of the auto PEEP, but with the NIV we can't calculate the auto PEEP.
So how will you adjust on the NIV to see that you are taking over this auto PEEP? You are helping the patient to get the tidal volume in, and this workup breathing is coming down or not.
We can set the I ratio and inspiratory flow in ventilator. We can set the inspiratory flow around 60 to 90, and I ratio with the expiratory time prolonged we can set. In a wise ratio 1:3 to 1:4 we can set.
Yeah. But you know, how do you know whether it's working? What you're doing?
Patient is getting adequate tidal volume or not?
What other markers would you look for?
Uh, we can check whether the respiratory rate is settled or not.
Whether the respiratory rate is a very sensitive marker there. What did you want to do on this patient? What did you do in the beginning now that you would like to do to reassess it?
Whether the tachycardia is settled or not, respiratory rate is settled or not, he is getting adequate saturation or not, 80 to 92% saturation is getting or not, and we can reassess with an ABG.
Yeah. So
To
quite
check for
important.
NIV failure, we can calculate the hacker score after 1 hour putting NIV. If the score is more than 5, there is chance for NIV failure, and we have to consider endotracheal intubation.
What's your hacker score?
Hacker score, the component include heart rate, acidosis, consciousness, oxygenation, which is given by PF ratio, and respiratory rate.
Yeah. So you've gone on to take a blood gas, and that's what you have got on Mr. H over there. Would you like to comment on that?
Here the blood gas is showing worsening pH, worsening PCO2. So the clinical situation is worsening, is showing the signs of NIV failure. And also the respiratory rate is around 40. He is also hypoxic with a saturation of 84%. So we need to proceed for an endotracheal intubation after discussing with the family.
So you've discussed with the families. Families agree that you'd like to give them a shot on on invasive ventilation. Just before you go on to that, how would you explain
Hello?
that rise in CO2 and the rise in lactate in this gas?
The PCO2 rises because of the because the proper ventilation is not happening because of the expiratory airflow limitation. The expiration is not complete. There maybe the dynamic hyperinflation can got worsened. The rise in lactate is mainly because of the respiratory muscle fatigue, which leading to increased lactate production. So all these signs.
Also, you've got salbutamol.
Yes, sir. Salbutamol also can lead to
cause your rise in lactate. What would be your induction strategy?
induction. We can select.
How do you induce
According to
this patient?
hemodynamic status of the patient, we can select the induction agents. We will here we will proceed with a rapid sequence intubation, either with the induction agent as an etomidate or a fentanyl can be given. Etomidate in the dose of 0.3 mg per kg or fentanyl 1 to 2 microgram per kilogram can be given as an induction agent.
Okay.
Then we can proceed with rapid sequence intubation.
Do we want to know anything else before inducing the patient?
We have to.
Do we want to optimize the patient before inducing?
We have to give the fluids. We have to optimize. We have to optimize whether VP is maintained or not. We can start on.
His VP is 90 by 40.
We can give IV fluids, adequate IV fluids, and also we can start on vasopressors as there is chance of hypertension post intubation is very high. We can start on vasopressors. Noradrenaline can be started because because of the autopip development, patient may go for hypertension. So induction agent can be changed if patient is in severe hypertension. We can select ketamine also. Ketamine is an induction agent also. It has a bronchodilatory property. So it is one of the choice in COPD patient.
Yeah, you can use the agent that you're more comfortable with and you're using it in this one. Ketamine, like you've mentioned, has an added advantage of causing bronchodilation, which would help you in this case. Be quite wary of this patient's crashing, because as soon as you switch them into an IPPV mode, those that are particularly intravascularly depleted can have a significant hypotensive episode that can lead on to cardiac arrest. How would you ventilate this patient? You've mentioned it previously already, Parul.
No. The ventilation strategy should be, we have to set FIA to respiratory rate of 12, 12 to 14. Then tidal volume of 6 to 8 ml per kg. We have to we can first of all, after intubation, we will be in a patient will be in a sedated paralyzed state. In that state, we can set the PPAS 0, and we have to set the inspiratory flow rate around 60 to 90 and I ratio 1:3 to 1:4. Once the patient start taking breath, we can set the PEEP around 4 to 5, and also we can check for any auto PEEP after the patient is adequately sedated and paralyzed by giving an expiratory pause and expiratory pause, and we can set the
Could you
PEEP
tell which
according to
mode you are going to
the
put the patient on?
volume control mode, sir. Volume control mode of
Okay,
ventilation.
so you have said all these things, but then you are not getting tidal volume.
Maybe
The
the
ventilator is
reason for
alarming.
maybe the peak pressures may be high because of this. Maybe there may be any obstruction or any bronchospasm. We have to check.
So what would you
The high
action?
pressure alarm is alarming.
We have to check whether the alarm is set properly or not.
Okay.
We have to
What do
set
you
the
do
alarm above
before?
that. Sir?
So yeah,
Can't-
you're told the right thing. Yes.
So we have to set the alarm above the above a limit. Then we have to check for other ventilatory connections are okay or not. Then we
Yeah,
can check.
the ventilator will not deliver the tidal volume unless you
We have to
adjust
check
the
whether any
alarm setting.
pneumothorax develop or not, because these patients are more chance for developing pneumothorax because of our positive pressure ventilation. He may develop pneumothorax. So by doing a lung ultrasound at the bedside, we can check whether he is having any ADAS profile or not. So if any pneumothorax is there, we have to do the emergency management for that. Then we can conduct.
So this is the scenario you get after 2 minutes of connecting the patient to the ventilator.
Most probable chance may be pneumothorax. By looking at the focus, we have to rule out that if the pneumothorax is not the culprit, we have
It
to.
takes a while for you to get the ultrasound machine, get the gel. Maybe the ultrasound is switched off as well. You have to switch it on. You'll again spend a bit more time. By that time, the patient will crash. What
How would you manage this
primary
patient,
thing?
Parul, with this sort of parameters that you've been given?
We can for blood pressure, we can start on vasopressor supports. We can increase the FiO2. Then we have to reduce the PEEP, and clinically we have to look for any pneumothorax, any air entry decreased or not.
Go back to your ABC then.
Yes, sir. Yes, sir.
You have a new critical incident here, and you have to go back to your ABCs again. You could be having a tube obstruction. You could be a big tenacious sputum. You could be having a lot of other things. So you start off again explaining to your examiner, or even in real life, this would be what I would do. I would go back to your ABCs, start off with the tube, come down and see what is happening to this patient. And yeah, tube obstruction, sputum retention, all of that can happen. Disconnection to the ventilator, all of those episodes can happen. But yeah, your hemodynamics would not be that. I agree with you, but you still have to rule it out in an emergency situation. These are the Bondo things that you shouldn't be missing on them. So you've done your ABC, you've come down. What you've noticed that there's a reduced air entry on the right side. and your airway pressure is significantly high. You have a high index of suspicion for a pneumothorax. What would you do?
Emergency intercostal drainage can be done either in the second or fifth intercostal space with a needle.
Okay. What is your pathogenesis of cardiovascular instability here?
Maybe because of the development of autopeep, patient went into
So you've got a
hypertension.
pneumothorax. You've got a pneumo. Why is the hemodynamic unstable?
Maybe
What has
because some
happened here?
bulla will be there. Because of the positive pressure, it may got rupture.
It has ruptured, yeah. But why are you having low blood pressure?
Because here there will be decrease in the venous return because of the positive pressure. That will lead to that will reduce RV preload and increase in the RV afterload, which also there will be increase the RV afterload. All these will lead to, in parallel to that, there will be decrease in the LV preload also.
Yeah.
Which
LV
will
preload, increase in LV preload. You're going to get a decrease in LV preload because you're not going to get enough venous return because of the obstruction. Isn't that, am I right?
Yes, sir.
Yeah. Right.
This will lead to decreased cardiac output and patient may go for hypertension.
Yeah. Pathogenesis of pneumothorax is quite an important critical care topic. We need to be knowing that quite, in and out. It's sort of one of the things that they might just drop in as a googly for you while you're thinking of focus fully onto your respiratory. All of a sudden, they just drop you a cardiovascular question just to test your knowledge. It's a very, I could ask you the pathogenesis of attention pneumothorax, cardiovascular instability as a separate question, and you would answer it without any hesitation. But they might just put it as an exam trick here. They like it a lot in the FICM. And EDIC also, I've heard they like it. But I don't know what the situation is there.
So what else you would be expecting? What is the most common other reason for this picture?
Other reason may be development of autopeep.
Yeah, dynamic
so
hyperinflation.
If patient went into a pericardiac arrest state, we can disconnect the ET tube from the ventilator, and whether the BP all
you have to tell
you
have to take away we can. You can tell I will immediately or something like that. You have to use that type of words. Okay, go on.
Yes, sir.
No problem. Go
on. Because of the dynamic hyperinflation, the autopeep got developed, and this can lead to cardiovascular collapse. So we can disconnect the patient from the ventilator and can check whether the vital parameters are improving or not.
Yeah.
As soon as you disconnect, and what you will expect if it is a dynamic hyperinflation.
If this is the dynamic hyperinflation, there will be improvement in the blood pressure. Because
also you get a significant escape of flow of gas from your ET tube. Once you've disconnected, all of a sudden you're getting a sort of release of the pressure. I've literally pressed onto chest and have had a significant, splurge of air coming from the ET tubes, and particularly asthmatics, not so much in COPDs. But dynamic hyperinflation would be more of that than anything else.
Okay. Coming to the ventilator graphics, how can you note whether the patient has got dynamic hyperinflation from the ventilator graphics?
The floating curve will show the start of the floating curve. The expiration will not touch. The next breath will start before the expiration touch on the baseline. And in volume time curve also, it will not touch the baseline. And in flow volume loop also, there will be, it will show some remaining volume in the end of expiration.
And any other maneuvers you can do to check whether there is a auto peep?
So we can connect to a manual ventilatory bag, whether it is filling or
Anything you do on
expiratory
the
hold
ventilator?
manual. Expiratory
Okay.
hold manual, sir. 0.5 second of expiratory hold, and we can check whether the total PEEP developing. From that, by subtracting the external PEEP, we can calculate the intrinsic PEEP.
Yeah.
Yeah. What are the cardiovascular complications expected in this patient? You've mentioned, I mean, it's a sequelae of a respiratory complication, but what are the cardiovascular complications would you expect in this patient? Thoroughly.
Right ventricular dysfunction can occur, sir.
Very common, yeah, quite common, particularly the severe ones. They always usually end up with cor pulmonale. What else?
Then, because of the autopsy, a patient can go for cardiac arrest because of the
What type
cardiovascular
of shock
collapse.
you are expecting in that type of scenario?
Vasodilators.
More common?
So you are already explained before. So it is fusing onto the heart. So what is it actually fusing onto? The
Because of
increased thoracic
the
pressure, what is it causing?
because of the pulmonary vessels get compressed because of the hyperinflation. There will be increase in
Yeah,
the pulmonary vascular resistance.
there can be increased pulmonary vascular resistance. Remember, your
Yes.
RV is not a very strong ventricle. Your right ventricle is a more stronger ventilation. Small increase in afterload can cause it to be impaired. And what you can get is an increase in pulmonary vascular resistance, which can lead to compromise or an obstructive like shock.
Obstructive shock. A pneumothorax,
Yeah,
secondary to
secondary.
Pneumothorax
pneumothorax.
also same physiology.
Yeah.
Obstructive shock can occur, sir. Then other complications, because of the prolonged ventilation, patient can develop ventilator-associated pneumonia.
No,
Then
cardiovascular
bad
other
outcome.
complication. You can get arrhythmias.
Arrhythmias also, sir. Atrial fibrillation and multifocal atrial tachycardia are common in patients with COPD.
What are the
Particularly when
reasons
you're
for
giving
that?
salbutamol and other drugs, you can always have those the side effects of those drugs. Aminophylline, all of those who have a cardiovascular toxic effect at a higher dose, and different patients will also react to it. Don't forget also salbutamol causes hypokalemia, which can again lead to arrhythmia also.
What other complications?
Then complications related to ventilator barotrauma can occur. Then ventilator-associated pneumonia can occur, pneumothorax. Then because of the other complications related to pneumonia, pneumonic effusion, then multi-organ dysfunction. Because of the sequelae of all this multi-organ dysfunction, like acute kidney injury, congestive heart failure can occur because of this RV dysfunction.
Okay, you have managed the patient very well, and now it's a stage when you have to decide whether to wean this patient. How do you assess readiness for weaning?
First of all, we have to look whether the primary pathology is resolved or not. Then, in an ABCD manner, whether his saturation is maintaining with the minimal FiO2 of less than 40%, his respiratory rate is less than 24. Then
Do you look
his
into
ABG
saturation
values.
or do you look into something else? Yeah, okay, go on. Sorry.
ABG values are got improved. Whether the acidosis got settled, pH get improved more than 7.35, and PCO2 improved to less than 45. Then the tracheal secretion is decreased or not. Then the patient is hemodynamically stable or not. We can put him on pressure support ventilation.
So, what are the modes in which you'll try to see whether this patient is ready for weaning? Would you try
We can
any particular?
pressure support or TP style can be given. Most of the COPD patient may fail TPs. So pressure support mode is preferred, and we can extubate the patient to NIV.
I'd be slightly careful in saying that, but there's no trial that has shown a superiority in pressure support versus TPs or anything. All the trials have been equivocal about weaning. So, I mean, yeah, pressure support, again, intuitively, it feels like a better mode in which you could drive this patient. You're slowly bringing it down, and then the patient would compensate for whatever drop in pressure you're bringing it. But there has been no trials that has, to my knowledge, that has shown a benefit with TPs versus pressure support ventilation. Do you know of any scoring system that can be used for weaning? Readiness of weaning.
Any index?
Any index?
Shallow index?
No, sir.
Rapid shallow breathing index.
Rapid
Index is one
shallow
of the
breathing
scoring.
index, sir. Respiratory
It's
rate
one of
by
yeah.
if it is more
That-
than 105.
Your
Then
chances are
after so
reliable?
many, yes, sir. Tidal volume
not
if it is
very.
adequate.
Not
Yes,
very.
sir.
I mean, it's you can use it. It use it as a guide, but it also has its failure. Everything in ICU has its failure rates. Unfortunately, we don't have 100% in most things. But yeah, it is a reliable. It has been used, but it's not very. 105 is the magic number that everybody quotes. Yeah.
Along with that, you have to use other parameters as to how the patient is, what you are told
Yeah.
anyway.
If adequate
I think
ventilation is not, or adequate tidal volume of 5 to 6 ml per kg is not, and the respiratory rate parameter, then CROP index is there. Then respiratory occlusion test P.1 or
I think one of the most important you mentioned it in the beginning was I'd look at reversibility of this patient's underlying pathology that caused his deterioration, and that's a very crucial factor in readiness for weaning. Okay, how would you extubation strategies as such the next?
Sir, we can, if the patient is passing the weaning test, we can extubate him to NIV, not to prevent
NIV has been
post-extubation
post-reintubation
failure.
failure. But unfortunately, our patient Mr. H has failed his weaning trial, spontaneous breathing trial. What are your strategies now? What would you consider for him? You can't extubate him.
First of all, we have to check the reason for failing. We have to address that.
He was quite tachypnic on the spontaneous breathing trial, and he just wasn't able to cope with the with loss of pressure support. Became fatigued very quickly, and then you stopped the trial.
We again have to put him on a control mode of ventilation.
You put him back on. Now, what's your escape plan?
The vicious cycle.
We have to we have to check the patient. What is the reason? If there is any bronchospasm or like that,
You
we
have
have to
done
address
everything.
You've,
we have to exit
you've
from
reversed
there.
everything. You've reversed
that.
everything. You've been
We have to wait till next day for giving another SBT trial.
Another person coming in and taking over. Is that right? No, we have to have an exit strategy.
He's
You're
failed
right.
also the next day, and the third day you come in, and now it's again the ball is back in your court.
We have to give.
What are your considerations now?
Once again, we have to put him over 30 minutes TP's trial. If he is
fails,
you gave it to your next person, and he also done the same thing, and you're giving it to you on the 5th day.
Then we have to then I will discuss with the bystanders regarding the possibility of prolonged ventilation.
He's awake.
Anything else?
He's awake.
He's awake. Anything else you'd want to consider?
look for any new infection, whether happened or not.
Everything is clear.
We can suggest tracheostomy.
Yeah, you could such as a tracheostomy. Any trials that have shown any superiority? Tracheostomy
No,
versus
sir.
non-tracheostomy.
No, sir.
Is
The
the
TrackMan
TrackMan?
trial and set.2 trial is sure there is no benefit in doing early. It compared
But
early versus late.
don't forget the exclusion group. Neurological patients were not included in that trial.
Yes.
Okay. So
Yes.
would you consider tracheostomy to wean him?
Yes, sir. We can consider as his functional status is only class 2 MMRC. We can discuss with the family members regarding the tracheostomy as he is difficult to wean from the
We
ventilator and he
already
may require
discussed
full of.
when you took the patient to the ICU, discussed the whole process itself. That if he fails, you will be doing a tracheostomy to weaning off. So everything has been discussed, and you again discussed that the patient is going to have a tracheostomy. So now the question is how tracheostomy helps in weaning him.
After tracheostomy, we can put him on any pressure support ventilation.
Now,
And
how
gradually
tracheostomy is going to help him in weaning?
we can reduce the dose of sedations. We
Yes.
can make the tracheostomy valve. By
Anything to do
providing
with
any
dead space?
speaking, dead space can be reduced, sir. So the patient may get adequate tidal volume.
Work of breathing?
Work of breathing also reduced with the pressure support. If we are putting on ventilator pressure support mode, we can reduce the work of breath also.
And is it easier than a long tube sitting there? Can the nurses do suction easily through a tracheostomy or a endotracheal tube?
Patient discomfort will be less than endotracheal tube.
Now the patient is weaned out or ready for weaning again, and you decrease, so you have top rolled the sedation, and secretions are coming down, and how will you go forward with weaning from the tracheostomy?
Weaning for tracheostomy, whether first of all we can change from the control mode to support mode. If he's tolerating support mode,
He's already on
also,
a support mode.
Support mode, we can reduce the values, and we can
Sorry,
we can continue with this. Gradually, we can change the tube into a speaking valve, and we can if he's tolerating all these things, he's able to maintain his airway with a speaking valve. We can do we can deflate the cuff, and we can wait for 24 hours.
you put the
And
patient
if
on
he's able
a
to protect
speaking
the
valve.
airway, we can lead him from the practice.
So you are telling that you are going to put the patient on a speaking valve without
Yes, sir.
deflating the cuff. Can't hear anything.
Sir, I lost the connection, sir. Can you hear me now?
Now, yes.
Hello, sir. I can't.
Mhm.
I didn't hear the question, sir. Pardon, I didn't hear the
Okay, so
question.
you have put on speaking valve and then you have deflated. So are you going to put the speaking valve before the you deflate the cuff?
It is only we can deflate the cuff.
I'm sorry, I can't hear you. Sorry, I
Hello.
didn't hear. Ah, yes, I can hear now. Now, yes.
Hello, sir. Can you hear me?
Yes.
Hello.
Yes, yes, still go on.
Sorry. Sir, we can put him on a speaking valve before deflation.
So what is the mechanism of speaking valve? How does the speaking valve works?
So not sure, sir.
It is a one-way valve, okay. The speaking valve
Yes,
is a
sir.
one-way valve, and you need to have the cuff deflated before putting in. Otherwise,
Okay,
it will not work. And also, the patient will trap air inside, and patient can't breathe out, and he will be in a distress and he will go into arrest. If you don't
yes, sir.
deflate, you have to know the mechanism of speaking valve, and before ordering for a speaking valve, patient should be cuffed down.
Okay.
And when you put this on, you have to put the cuff down. What all measures you will take before putting the cuff down?
Sir, measures before deflation only, sir.
Before deflating the cuff, what do you do? Basically, just think that you're in the ICU by the bedside. You're going to deflate the cuff. What do you do before that?
I will check whether there is no secretion or not. We have to arrange for an emergency airway equipment should be kept ready before decannulation only,
Why?
sir.
No, it's not decannulation. Deflating the cuff.
Deflation.
We haven't reached to decannulation. We are just sitting around deflation of the
Deflation.
cuff. So you do subglottic suction, get the
Yes, sir.
secretion out,
Mm.
and you deflate the cuff. What are you going to achieve? What are you going to check with deflating the cuff?
Whether the patient is patient again go for in respiratory distress, whether he is able to protect his airway, whether his swallowing reflex is okay or not.
Yes, yeah. You can protect, and you're looking for cuff reflex, whether he can retain, whether he, yeah, that's all. You're told everything. Laryngeal competence and bulbar function. That is what you're looking into.
Yes,
Deflating
sir.
the cuff. Does it help in weaning him off the ventilation?
Yes, sir. If he's able to protect his airway, we can consider deflation.
Okay. And talking back on the what were we telling about the speaking valve? How does that help?
Speaking well, in that we will be able to assess his airway.
Yeah, it's improves when you deflate the cuff and put him on a speaking wall, he can speak. That
Yes.
psychologically it helps him and
Okay.
restores his body pressure. So it helps him to close the glottis against that, and then get his PEEP in so that he can breathe in. Okay, against
Okay,
the against his constricted airway. Then improves his cuff. This also improves swallowing. Okay. Then the weaning method you told pressure support ventilation and pressure support mode. Or is there any other method you can do to wean him
The
off?
newer methods are there, neurally assisted ventilation, NAVA method, and then proportional assisted ventilation. These are the newer method which help in weaning. In NAVA method, by assessing the diaphragmatic activity, we can try weaning the patient out of the ventilator. In proportional assisted ventilation also, the ventilator itself can adjust according to the patient's requirement, and gradually we can wean the patient from the ventilator.
Okay. Do you use that regularly?
No, sir.
So you tell me something which you use in your ICU on a regular basis for your patient.
Pressure support ventilation or TP trial are the usual method of wean student ICU.
You can put on a trachea mask.
In tracheostomy patient, we
You
can
do
put a
that?
tracheostomy. Yes, sir.
Trachea mask. Okay. And what are the criteria? Decannulation. So you have done that, and patient has successfully passed all those things. And what is the criteria for decannulation?
Decannulation criteria, again, the patient is able to protect the airway, the swallowing reflex got improved. Patient is not in any respiratory distress. He is able to clear the secretions in the 24 to 48-hour period. We can observe him with a deflated cough. If it is okay, we can decannulate the tracheostomy.
Okay. Okay, very good. And you mentioned about the secretion, as you have mentioned. So now coming to day 21. So this is a scenario which unfortunately the man has gone through another pathway. Day 21 intensive care now. So you have tried everything, tracheostomy, and despite treating pneumonia, he has severe ICU acute weakness now. Every time you try to reduce the pressure support below 20 centimeter water, he becomes distressed and retains carbon dioxide. So you are not able to wean him. He has now developed a new renal failure, recurring dialysis, and his skin is breaking down. So the consultant body has agrees that, and you discuss with multiple consultants, your colleagues, and come to a conclusion that lung changes, muscle growths are irreversible. Further treatment is prolonging the dying process, not facilitating his recovery. Okay. Before you speak to the family. What is specific legal framework you use to make the decision with the patient's lacks capacity?
We can talk the family. I can talk to the family in end of life care mode. I have to discuss with the other physicians regarding his present
That's
condition.
all discussed. So then, I will take away this question because the legal framework may be different in different countries. So I'll take that away.
Advanced medical directive. Advanced medical directives is approved in India now.
That's not advanced. That we have discussed earlier. That's the respect form which we are discussing initially before taking the patient to ICU. So that's not what I was mentioning about some mental capacity act or something like that. We got an act here. So if you have a mental capacity act, the patient, it's about the capacity question. Before speaking to the family, if the patient has capacity to talk to the patient, if it doesn't have capacity, you have to talk to the next of kin. Okay. So that I'm not aware about the recent updates there, but anyway, that I will take away from the question. A family meeting with next of kin. So you're sitting with the next of kin, Mrs. H.
Yeah, I mean, the important thing is don't forget to discuss. If your patient has capacity, you have to discuss it with the patient also about what would be their wishes also. If they don't, most of the time we have a group. Fortunately, unfortunately, we deal with a group of patients that don't have the capacity. So we have to discuss it in the next of kin. But sometimes you have to discuss it with the patient also.
Okay, if the patient has capacity, you discuss with the patient and check with the patient if they're happy for the family members to be involved in the discussion. Then if the patient is not happy, then you have to discuss with the patient. So the capacity always matters when discussing the treatment pathway. Okay. So unfortunately, our patient doesn't have capacity. So you're discussing with his wife, Ms. H. She's distressed. But he say fire. So you discussed that this patient is from the consultant board. You have concluded that the patient is not going to survive, and whatever you're doing is futile, and the patient is unfortunately going to die. I told the patient about that, but then she says, "He's a fighter. You can't just give up on him." So how do you explain the transfer active treatment to palliation without making her feel like you're abandoning him?
I can talk in a spike model pattern. I have to, first of all, I should adopt a proper setting and ask the patient bystander what they know about his current illness and what is their expectations. Then I will explain the bystander regarding his current situation and we did our all active treatment till the date, but he's not responding. He's in a futile stage. So we can, if the family members are okay, we can provide him a palliative manner. We can provide a palliative treatment we can shift the care from we can shift the treatment from cure to care by providing patient comfort, his dignity, all. We can discuss in an end of life manner by providing him only the supportive care, and we can shift out him from the ICU and be with his family members in the ward by providing other supportive measures. If they are okay, we can proceed with that.
Okay, they are not okay. So what will you do?
We will continue him on ICUs by providing the by providing ventilatory support with the tracheostomy. And physician is allowed. No, sir.
And next day, your colleague comes in and talks to the family again, Mrs. H again, and says that the patient is unfortunately working on all the treatment which he needed. We have supported him actively and to the maximum which we can until now. And unfortunately, he's not making any progress or he's showing deterioration. Came in with one organ failure and is deteriorated to 2 or 3 organ failures now. There is no point and he's weak. What exactly happens to the muscles when someone comes to an ICU on a ventilator? What happens to the muscle strength? His FEV1 was less than 30%. Now it's 21 days in ICU.
Maybe he developed ICU-acquired weakness because of the multiple factors. First of all, because of the ventilator, diaphragmatic dysfunction can occur. Then nutritional therapy may not be appropriate because of the use of the steroids also, which can aggravate the ICU-acquired weakness.
Always the nutrition therapy helps. What will be your nutrition strategy?
Nutritional strategy in the initial hours, we can start with hypocaloric and gradually build up the nutrition within 1 week to isocaloric strategy with adequate protein. This COPD patient maybe already maybe protein malnourished, so we can provide him with a 1.5 to 2 gram per kilogram of protein, and also the physical rehabilitation. Also, we have to give adequately. Otherwise, there is increased chance of muscle dysfunction. And a patient is on prolonged ventilation for more than 7 days, and patient with a pre-existing hyperglycemia or hypoalbuminemia are also more prone to develop this ICU-acquired weakness. Most of this COPD patient, there is increased disease atrophy can also occur. Those who are on prolonged mechanical ventilation, these are also prone to develop the ICU-acquired weakness.
Okay, now the family has come into an agreement that he is dying, and this dying process should be dignified. He needs to have he needs to go through the palliative process, and he should have a dignified death. Okay, without extending his suffering. So you put, what do you do then?
We have to withdraw and withhold the life supporting measures that we are providing. Then we
How do you
can.
do that? Just pull everything out, or?
No, sir. We are gradually decreasing everything, and we can provide any analgesic
So here
to
you are not
decrease.
going to wean the patient. You are not going to gradually decrease. So what
Uh,
exact palliative measures you do in an ICU?
we
When a
can
patient is on a palliative pathway, what exact pathway they are put on? Is there a formal way you do that?
in a formal way we can do after discussing if we got the consent from the bystanders.
So yeah, it's all consent is done. What?
Then we can
How do you
withdraw.
do that?
We can
How
withdraw.
do you? That's what I am asking. How do you do the withdrawal?
We can directly withdraw the life supporting. If he is on any vasopressor support, we can stop that. We can reduce the ventilatory settings, and we can provide any analgesics to decrease the discomfort of the patient. We can give a comfort care for.
Yeah, what is that comfort care? That is what I am asking. Just tell what you do there.
We can provide any analgesic support, any analgesic infusion. We can stop the vasopressor support.
Yeah.
Yes, yes.
I mean, you're primarily now aiming for symptomatic management, Parvati. So you're looking at the things that the patients suffer most at the end of the life, things like agitation, pain, and secretions. So those are the primary three things that you probably need to address for them at this point of time. So agitations, you give them a dose of sedative agents or anxiolytics. It can be whatever your choice is. There's nothing right or wrong. Pain relief, whatever can be given, and secretions like a palliative, whatever it is. We stop all treatment, whatever supportive treatment we have been giving this patient, and start them off at that point of time onto those onto comfort care.
Yes,
I mean, different people have different ways of doing it. I just stop everything and extubate the patient. If the patient has been on a propofol alpha-enteral, which is our mode of sedation and analgesia, I just continue with that. Some people like to switch them on to a morphine midazolam infusion or some other form of infusion. There's no right or wrong way. It's all personal choice there.
okay.
So what else would you have to consider? What else would you consider in this patient before fully withdrawing? Anything else that you can?
This patient is also in already in a multi-organ failure. We can't consider him for any organ donation.
You can consider nowadays we do a lot of tissue donation, so cornea tissues can be considered in this group of patients.
We can involve other transplant if it is salvageable. We can include other transplant people to discuss with the bystander regarding the organ donation.
Yeah, definitely. I mean, yeah, I agree with you. You said likelihood of him donating his heart or lung is extremely unlikely, or liver, for that matter. But you could consider things like cornea or tissues, which is becoming more and more of a field which we're doing more and more of them. Sorry, carry on.
We can coordinate with the transplant people. We can coordinate with the transplant people and discuss with the family regarding the same, and can consider for any tissue transplant only, because organ transplant, as this patient is in multi-organ failure, it may not be suitable. The organ may not be in a preserved state to transplant to another person.
Yeah. Sorry, Sunesh, I interrupted.
Yes. That's all. I completed our presentation. Well done. We both have answered very well. Okay. And in EDIC examinations, you get the scenario, you get the questions, and you get the answers as well to the examiner. So as you talk through whatever you tell, you say the answer only, you will get the mark. Whatever is written, whatever is given as answer, we have to just take it off. Okay. So that if the answer, whatever you're telling, the answer is there, you'll get the mark.
Okay.
So we won't judge ourselves. The question and answer is given to the EDIC examiners. I don't know how your DRNB exams are.
You have a crap sheet here normally. So if you have the classic, when I was giving my exam, was that they had an upper airway obstruction, and the word they wanted was seesaw breathing. And so they kept asking, what else would you see? What else is there? As soon as I said seesaw breathing, they ticked the box. And I could see them ticking the box there. So there will be specific words in the crap sheet. And if you say that word, you pass. You get the marks. That is how they operate here. I mean, for the EDIC as well as the FFICM. So if they're asking what else, they're probably looking for a word, some word that they want you to say. They're not trying to trap you. Sometimes, most of the time, they're trying to get the right answer out of you.
Thank you, sir.
But I think you did very well. Your knowledge base is quite sound. Just a bit of polishing up in your presentation skills about how you answer a question. I think otherwise your knowledge level, and I don't know how it is there. So I can't tell you that. But if you are going for EDIC or FFIC, you stand a good chance of passing.
Thanks.
You should be confident, and you should be telling, I will do. You say that I do this. Okay.
Okay. Okay. Thanks.
So you are at the last. So what they consider is on a Friday night, whether you can manage the ICU till Monday. That's what they're looking into. If you are a safe doctor who can keep the patients alive until Monday, then you are a pass. So what you do is not I will do. But it's looking whether you're safe doctor. So confidently that I will do.
Yes.
I will do this. Don't tell what you're telling. I forgot. Is it? You can. Don't use you can. I will.
So come forward confident, Parvati, and don't be bogged down with small numbers. Is it 1 milligram or 2 milligrams and all of those? Don't be worried about that. What you can always say, in the modern world where you've got the whole internet at your fingertip, is it 1 milligram or 2 milligram? You will have time to look it up on the internet, in anywhere in this world. So nobody is going to. I would find it very cruel that everybody is going to mark you down for saying a wrong. That sort of a number. Don't say anything, totally out of the world. But come forward. You come forward more confident. Don't be bogged down by the smaller details. Have your broad management of a patient in a safe way, whatever your condition is, and that's what your main aim is in this sort of exams. ICU is full of pitholes about how different people manage different things. So there is no 100% correct way in most cases. There is a right way and there's a wrong way. As long as you stay within that safe boundaries of the right way, you should be fine.
Okay.
Okay.
Thank you, sir.
That's it. Thank you.
Should we complete?
Yes.
Thank you, sir. I think it's been an excellent session, close to about 2 hours. Heartfelt thank you to both the examiners for sharing your invaluable insights and your global perspectives. It was really useful for the Indian students. To our enthusiastic examinees, it was also all the questions were very well answered. I think we have quite a good feedback from some of the senior faculties like Dr. Santi and many other doctors who they've been personally texting me. So I think overall the students would have got highly benefited out of today's program. So once again, I thank both the examiners and the students, both of you, for your valuable participation today. Thank you very much. Have a great weekend.
Thank you.
Thank you.
Thank you. Thank you, Sunesh. Thank you, Dr. Sunesh. Thank you, Dr.
Okay.
Sir.
Thank you.